Welcome to this ASAIO Journal webinar presented in collaboration with CTSNet, Donor Heart Preservation and Resuscitating Marginal Donors, Hot or Cold. Thank you for joining us. Please note this webinar is being recorded and will be available next Tuesday on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the host for this webinar, Dr. Mark Slaughter. Dr. Slaughter, Editor-in-Chief for the ASAIO Journal, is a professor and a chair for the Department of Cardiovascular and Thoracic Surgery at the University of Louisville. He also serves as the Director of Heart Transplant and Mechanical Assist Devices at the same institution. Thank you for joining us, Dr. Slaughter. I'll turn the panel over to you.
Thank you very much, John. We're very excited. The topic today, I think, is one that's not only unique, but extremely important. Certainly, the expansion of the donor pool the last few years has been extremely important for the growth of transplantation. Initially, it seemed as if there were just a few programs, as I say, sort of dabbling in DCD, but it appears as though it's here to stay and most likely needs to be a significant part of all programs. So what we've done is we've put together an expert panel to discuss current trends in the DCD and transplant world, and subsequently sort of the differing approaches for these what are sort of different donors that require sort of a different approach, different evaluation, and certainly the logistics are very different. So hopefully we'll be able to get some great insights into programs that are extremely busy, have been doing it for a while. Dr. Protos was not able to join us today. He had an emergency surgery. So I will be moderating the session in his absence. Dr. Schumer is assistant professor here at the University of Louisville and the associate director of our transplant and MCS program. And she'll be monitoring the chat room and collecting questions and themes, which we'll bring forward. So hopefully everyone will go ahead and submit questions. So if we could, John, we'll go ahead and proceed. As we can see here, our panelists, I think most likely everyone knows them all, but Dr. Bowdish from Cedars-Sinai, Dr. D'Alessandro from Mass General, and Dr. Silvestry from Orlando, Florida, will be speaking to us today and participating. Hopefully what will be a lively discussion. So what I'd like to do is we're going to start out with Dr. Bowdish, the professor and clinical chief. And if you can pull up the first polling question, John, as he loads his slides. So the first question is just to get an idea of the audience. Does your program accept or do DCD organs? Some programs still are hesitant, mainly because of the team that's required. Some
What happened?
We break the internet?
I think so.
Did we break the internet? Did I break it when I tried to share my slides?
That's okay, Dr. Bowdish. Why don't you go ahead and pull up your slides, and we'll just proceed with the first presentation.
And is that working?
Yes.
Okay, perfect. Thank you, Mark.
There we go. Just real quickly. So still a third of the audience is not yet participating. And interestingly, or NRP only. And it's sort of equal distribution there between both and OCS only. So a nice background. Great. So why don't you go ahead, Dr. Bowdish?
All right. So thank you very much for inviting me to participate in this webinar. Dr. Slaughter always gives me an interesting topic when I present for him. And so the first part of this is easy. The second part is a little harder. So I want to talk a little bit about DCD. I pay heart and heart because we'll talk about DCD and heart and the national trends and variable variability we see in states, and you'll see that that's okay. This is interesting. Okay, my disclosures are here. This is so. As everyone on the call probably knows, there's really two different ways that we can procure hearts. The traditional, we call it the traditional donation after brain death, and then donation after circulatory death. And I think we, at least those of us that were perhaps not at the forefront of heart transplantation, but more in their mid careers, think of DBD as sort of the way that hearts were actually procured. And when in fact, actually the very first heart transplant, the patient was probably brain dead, but the organ harvest was actually performed more in line with the DCD technique. And this is, if anyone's interested, this is, you can find this on the internet. This is the actual operative report from Dr. Barnard. And if you read this, they describe a situation where the donor had been certified dead, but South Africa had just introduced brain death laws. And I think they were a little bit hesitant to accept that as actually legal death. The patient was brought to the operating room. The chest was opened rapidly, and a median sternotomy. I'm sorry, the patient was brought to the operating room and waited for the patient to have no cardiac activity for 5 minutes and no spontaneous respiration. So that's basically a DCD donor. They opened up the chest, put the patient on a bypass circuit, and then harvested the organ. So effectively, the first donor was actually a DCD. And the big difference, here's the brain dead donor that we're all relatively familiar with, the heart's beating, and we versus a DCD donor. And this is always, shocking to some people who've never done this or seen this. It is a dead person. So the heart is completely, as you'll see here in a minute, completely asystolic. The patient is the person who's basically a corpse at this point is completely dead. So how we reanimate and assess those organs is very different. So Mark asked me to talk about, well, how the actual trends in this. And so the latest data from the OPTN and SRTR that's available is from 2022. And in 2022, there were just under 15,000 deceased donors, over which roughly 10,000 were brain dead donors and 4,800 were DCD donors, which represents a 14% increase over 2021. And if you pull out the figures from this, you can see that the number of DCD donors has increased, significantly from only several hundred, up to that close to 5,000 mark. And this is obviously for all organs. If you look at organs transplanted per donor by type, DBD or DCD, you see that overall DCD organs per donor is about the same. But if you look at the heart only curve, you can see that the incidence of hearts transplanted per donor has increased, especially after 2019 and the study of really the OCS study from the US, multi-center study from the US. So there's definitely been an increase in use of DCD organs in the United States. Now, if you look at regional variations, it's interesting. If you try to look at, this is a picture of donation rates across all the donor, all the DSAs in the US. And then this is percentage of DCD donors from those same DSAs. So you would expect if the transplant rate and the DCD rates are the same, these colors should basically be the same. But you definitely see some areas where they're light blue here, Colorado, Oklahoma, Colorado, Wyoming, New Mexico, whereas they're dark blue here, but they're light blue here. California, LA is fairly light, and we'll show some of that in a minute. So there's definitely a discrepancy, although getting real state specific and OPO and DCD and DSA specific data is a little bit challenging. One of the things that we've been interested in is this is some work going to be presented at AATS. This is from the abstract. The prediction of prognosis of heart donors is difficult, and in roughly the 5,200 heart runs that are in the UNOS database, only about these numbers are quite. There are only about 800 that actually expired. So, and of these 800, about 718 progressed to donation. So, if you go out on a heart run to get an organ, you've got about a 50-50 chance of getting the organ. And that's one of the challenges with DCD is the time and the resources and the fact that really only about half the time you come back with an organ. This is work being presented also at ATS, just showing again the similar to before, the increase that we've seen in DCD hearts over the last 4 years. This group updated the UNOS database at the STS just a few months ago. Similar, you can see the increase in DCDs. And on that slide, you also see that NRP represents about, roughly half of what was at least done in June, at least in the last year. So it is there is a little bit of a divide between the two types. We've done some work also with the UNOS database, that basically demonstrates that there is a skew to the left, in that there are centers that are doing a DCD, and those that are doing it tend to be doing a fair amount of it, versus on the other side, centers that are doing less. We've also this is being presented at ISHLT. This is from the abstract. This is similar dating, but looking at outcomes, and there is an outcome or volume outcome relationship between those that are doing more DCDs than those that are doing less. What about the regional aspects of DBD versus DCD? My One Legacy OPO here in Los Angeles or in Southern California was nice enough to provide some of this from a meeting we had last week, and they've had a real impetus to increase the use of DCD donors. So if they looked at 22 versus 2023 donors, there was a 6% increase in donors overall, but a 29% increase in the use of DCD donors within our OPO, our local OPO. All of California OPOs, there was a 10% increase in organ donation and a 27% increase in DCD. So in California, we've been a little bit slow to adopt DCD, at least among the OPOs, but they have made inroads. And nationally, you can see last year there was a 22% increase in use of DCD donors. So I know anecdotally that, we're far more likely to go to states like Oregon, Washington, Colorado, Arizona for a DCD donor than we are to go 20 miles down the street for one. So there is definitely regional variation. Survival has been overall equivalent between DCD and DBD, although there are some sort of numerical differences that may or may not turn out to actually be, significant long run. This was part of that presentation presented at the STS. And then interestingly, if you look at NRP versus direct procurement, this is risk-adjusted non-use rate. So you're actually appear to be more likely to actually use the organ if you do it with NRP versus the OCS or direct procurement system. At Cedars, this is a few weeks old. We've gone out on roughly 59, I think now, donor attempts. We've had 32 progress. We've done 7 by NRP and 25 by OCS. We have started to use, at least for about half of these, the national OCS procurement system. Here's some numbers. Our average pump time on OCS was 250 minutes, so a little around 4 hours. And average time on NRP was 41 minutes. That kind of varies from very short to very long. And our at least initial survival here is very, very good with both. All of our NRPs that have lived at least out to a year, but the numbers are very, very small. So I think, the key points here is there clearly has been a large increase in DCD heart donation since 2019. I think it does have the potential to alter the landscape of organ donation significantly. Is it for every center? I think that's for centers to you have to just decide. We didn't talk about the logistics, but that's an interesting topic we could talk about. There's clearly variability by state, region, and the OPO. And I think this requires further study, and there's obviously opportunities to really come together and collaborate if we're really going to have a widespread adoption of these programs. And with that, Mark, I'll say thank you and turn it over to the next speaker.
Yeah. So, Michael, it's a great way to get the conversation going here. And real quickly, one question now. Sort of the slide you showed, sort of the distribution of who's doing it more frequently, it tends to be the higher volume programs. But just roughly speaking, though, still about half of heart transplants in the US are done by programs that do sort of 10 to 16 a year. So it seems as though, because of sort of the team that's required, the expense and whatnot, it's challenging perhaps for them. I mean, once again, they do a good job. There's got to be a reason why. But if the outcome's the same, it seems as though the potential recipients at these programs might be disadvantaged going forward if not all programs participate. What are your thoughts?
Yeah, I think you're right. You're right on the point that I do. The resources I have a whole nother talk on the resources. It's a huge investment and it takes a huge team to do it. I think what we have definitely, we've definitely transplanted people that we wouldn't have gotten organs for without the DCD option. So I think you're right that I think that's sort of the dilemma here, is that I do think we can move through our list quicker because of the option of trying to screen these DCD donors. The challenge, I think, is actually, if I could predict, who's going to progress, and know that I could do that 80% of the time, it would actually make the return on that investment much better. When it's sort of a flip of a coin, it's a bit of a crapshoot, right? So one of my challenges is, like, I'm pretty sure that most DCD donors you go out on, those people, eventually all expire. Each hospital has these time limits. So it's 60 minutes, it's 90 minutes, it's 120 minutes, and you can only wait that long. And, a heart that continues to beat with a blood pressure of 120/80 for 2 hours, just because we say that we can't do a DCD on that anymore because of a regulatory thing, that person probably died 6 hours later. We don't know, right? But so but it's definitely resource intensive. And I think I really do, we at Cedars really do view it as a way to expand the program and the ability to transplant patients. And I don't have this slide, but many of our DCD hearts have gone to patients that are, status 4, status 5, people from home, that are actually, quite honestly, either, doing well or sort of, that may not have gotten an organ for, who knows, so that's how we view it.
Mark, so that's a fascinating point, Michael. If you look at Dave Kazarowski's paper, which was the Chamberlain paper at the AATS last year, it's exactly that data, that the actual advantage went to status 4s and blood type Bs, whereas we would think that it goes to status 1s and 2s and blood type Os. And the benefit is in decongesting the liver, and there are other aspects about it. But Michael, you also touched on something which is critically important, and that's the democratization of the resources. So Cedars does a lot of transplants and has a resource. There are entities, and we're trying to build a network of cooperation between centers so that centers can field local DCDs by NRP, because the data does support that. And the data also allows you to look at a heart and assess a heart more thoroughly, to trust in a center. Michael's in LA. If he called me when I was in Texas and said, Scott, can you do an NRP for me? I would say, absolutely. We would do an NRP. We would do a transesophageal echo. We've done this in Philadelphia. We would give him hemodynamic measurements. We would come off of the NRP support, and then he can make a decision as to whether the heart is worthwhile for him and his recipient. In that sense, the plane would be one way, and there would only be a standby fee. So we have to do 3 things. We have to decrease the resources that are beholden upon a center for non-use or non-passage if the donor doesn't go or if the heart is unacceptable. We have to extend our courtesy and our resources locally where it's cheaper to our colleagues who have recipients in remote location, so that we can get hearts to people who will use them. It will ultimately benefit everybody. And we need to collect better data in order to know which hearts, what times, and what methods are the best way of procuring the hearts for effective transplantation. The data that Michael presented is similar to data Nader Moazzami presented at the AATS in Toronto, which shows a small but real, not statistically, but maybe clinically significant difference between NRP and DPP. And looking at 1 year, and then now looking at to 3 years. The SRTR does not collect data such as warm ischemic time. It does not collect the methods previously in the early phase. And so a lot of what we're doing is blind, and a DCD is not a DCD is not a DCD. They're not all the same, and extending the benefit to our patients requires us being rigorous in collecting data, analyzing it, and being honest about it.
I think Scott just summarized the entire webinar for us. So very good. So why don't we pull up the next polling question? So we'll get into the hot versus cold, because I do think, as you sort of suggested, though, people have a little bit different experience, maybe due to teams, and we seem to be developing a couple camps. So why don't people quickly vote as to what they think might be best, and then we'll have Dr. D'Alessandro pull up his slides. And here we go. So next, Dr. D'Alessandro is the Associate Chief and Clinical Operation and Cardiac Surgery and Associate Professor at Harvard. And as soon as we get the answer here, and in just a second, too, we'll have Dr. Schumer see if we have some common themes popping up. So interestingly, just in general, if we group them, it appears as though it's a little bit 50-50, but maybe a trend towards cold might be better than the warm continuous perfusion. All right, David, take over.
Thanks. Just want to thank Dr. Slaughter, ASAIO, the webinar organizers, for allowing me to be part of this important webinar on donor heart preservation with respect to transplantation. Just before I begin, I just want to address Scott's point, because I think I heard him suggest that NRP was superior to OCS. I'll just remind you that there's one randomized prospective clinical trial looking at DCD compared to cold storage, and it shows no difference in survival, and actually numerically better survival in the OCS DCD group. So I think we got to be careful with those comparisons. I'll let you have the mic later, but for now I'll hold on to it. Here are my disclosures. My topic was cold preservation, the return of the ice age. I'm having a little trouble advancing my slides. Let me try this button, excuse me. That works. There are my disclosures. So as we discussed already, and as this audience knows well, a lot has changed in heart transplantation over the last decade. To begin with, there's a new allocation system, which is not so new anymore. It's more than 5 years ago. But this allocation system requires that we're traveling further, and as a consequence, our organs are suffering a longer ischemic time. We're evaluating more donors than ever before. That's costly, it's time consuming, and we're doing more transplants than ever before. In 2023 in the United States, we did more transplants than in any prior calendar year, and that appears to be a trend that's continuing. As we all know, that there's increased scrutiny on programmatic metrics. Public reporting is very real, so it's really imperative that we continue to maintain outstanding outcomes, lest our programs suffer. And as was discussed, DCD, which was the way the early transplants were done, has returned to the clinic. And we're now more and more looking at extended criteria donor hearts. And so the bar in transplantation has gone up, and it's a requirement that we have now better preservation technologies in order to maintain those outcomes. So while my topic is return to the ice age, I don't think we've really necessarily ever left the ice age, although I would argue that the ice age is evolving. For most of the last 50 plus years in transplant, as people know, we've relied pretty heavily on simple ice storage. This was inexpensive and gave us a rather reproducible, safe period of time, up to about 6 hours, that we could procure our organs and transplant them back to our implanting centers. And that's what we've all used for most of our professional careers. There's been a pretty rapid evolution over the last 5 years in the practice of transplant and how we've preserved and maintained our donor organs. And we'll just talk about a couple of those briefly. My topic was to discuss the hypothermic one. And with respect to hypothermic, we have static systems, which are either ice, which maintains the donor heart between 0 and 4 degrees Celsius. But as we've learned in the past and continue to learn, it appears that those temperatures closer to 0 can be problematic. There's evidence that there's cellular and organ damage at those colder temperatures. And so the Sherpa is the only approved transport device, static storage device that's designed to maintain the donor organ at warmer temperatures between 4 and 8 degrees Celsius, as I'll show you. And I'll just briefly mention the ex vivo system. Scott is the national PI on this, which is now undergoing clinical trials, so I won't say too much. So I'll talk mostly about the Sherpa Pack system because I think this has a growing market share, which I think is around 50% of donor hearts right now that are done without a perfusion system. As you may know, it's a hard container in which the donor heart is suspended in whatever preservation solution our centers prefer. That container is then placed within another container and placed within that styrofoam transport disposable container there shown on the right. There's a proprietary phase change ice packs that are in there that maintain that heart within a narrow range of temperatures. There's a nice little readout on the surface there that you can see that's partially cut out that gives you the temperature during transport. And there's even a nice GPS tracking system that will beam to your phone that allows you to keep track of your organ during the transport process. We started using this device in 2019. This was the first 20 hearts we put on there. And you can see that it's pretty effective at maintaining the heart between 4 and 8 degrees Celsius over prolonged periods of time. And that's what it's designed to do. So we and others are participating in this Guardian Heart Registry, and you've probably heard some of the data that's presented from this registry. It's a retrospective data registry of patients that were transplanted with either the Sherpa system or with ice storage. So centers that participate prospectively enter their Sherpa Pack patients and then retrospectively enter their iced storage cohort in a roughly 1-to-1 fashion so that we have equal numbers of patients. And we now have more than 1,800 patients in the database. This is both in the US and Europe, but the majority of these patients are in the US. And we can begin to make some important comparisons looking at outcomes between these groups. So this is data that was presented by Ariel at the HFSA last year. And so starting in the registry with more than 1,100 patients by matching for age, ischemic time, the post-2018 allocation era, and the presence of a durable LVAD, we get 353 patients in each group that are pretty well matched for the clinical characteristics as shown here. And when we compare outcomes, you see a rather striking reduction in the dependence of post-transplant mechanical circulatory support of any kind. We see a 40% reduction in the need for post-transplant VAD or ECMO, and we see a 50% reduction in severe PGD, which is just over 5% in the Sherpa system compared to 11% in the ice storage system. And again, these are patients with very similar ischemic times. When you look at RV dysfunction, we similarly see less moderate or severe RV dysfunction in the Sherpa group, just under 20% compared to 28%. We see the inotrope scores at 24 hours are reduced, and we see a clinically significant reduction in ICU length of stay, which was just over 2.5 days on average, and a trend towards a reduction in the total length of stay in these hospitalizations. When we look at the effect of the Sherpa system on survival, we continue to see this trend towards an improved survival, but has not yet achieved statistical significance with a p-value there of 0.09. Now, this is data that I presented last year at the ISHLT. If we use logistic regression to generate these probability curves, looking at predicted probability of severe PGD as a function of ischemic time, If you use the iced storage cohort, you see this rather familiar curve where you get a pretty steep increased risk of severe PGD with each hour of additional ischemia. If you generate the same curves using the Sherpa group, you see a marked reduction in that risk across all ischemic times. At no ischemic time does ICE look superior to Sherpa, even the very short times, and at all times does it look better. And so just by example there, if you look at ICE, there's a 10% risk of severe PGD when you get to 3 hours of ischemic time. That's about 6 hours of ischemic time using the Sherpa system. And this is highly statistically significant with a p-value of 0.009. So it certainly appears that using the Sherpa system, ischemic time is now a modifiable risk factor. Well, we were emboldened by this knowledge last year to take a heart from as far away as Alaska. This was a heart that we could not get a perfusion system to. We just didn't have the time and the planes to get there. We used the Sherpa system and flew that heart almost 3,000 miles back. And despite an ischemic time of almost 7.5 hours, that patient did really well. He was transplanted by Ali Rabi in our group. He had no PGD and was discharged home within a few weeks. So it's an example that this is possible. Whether this is reproducible, we have yet to learn. I'll just briefly mention the ex vivo system because this is the other hypothermic system that's a perfusion system, and again takes advantage of that similar temperature of 8 degrees Celsius. It's a low pressure perfusion using a proprietary cellular perfusate. And not to be outdone, these authors just recently published the first transatlantic flight of a donor heart on a commercial airplane flying more than 4,000 miles from the French West Indies to France. And despite a perfusion time of more than 12 hours, that patient similarly did very well. No PGD and a short hospitalization. These next few slides were given to me by John Trahanis and Ash Shah at Vanderbilt. And I think it's worth mentioning, many of you have probably kept abreast of what's been going on in lung transplantation, where it appears that 10 degrees is an optimal temperature for the preservation of lungs. At Vanderbilt, they've been exploring 10 degrees with their hearts. They've done almost 50 now, beginning in the summer of last year. This is the Trafurox cooler, which is designed for 10 degrees storage. I wrote in the zeroing in on temperature. I don't know that we're zeroing in on the optimal temperature just yet, but it certainly appears that the optimal temperature is not zero, at the temperature that we've relied on in the past. There's an example of a temperature gun there, just showing a heart coming out of that system at 10 degrees. This is just some of their data. They've got 30, excluding patients that were multi-organ and other sort of high-risk features, a 30 less high-risk group. You'll see that more than 50% of this cohort is DCD. So this is both brain dead and DCD organs. Sorry, going the wrong way. And you see pretty impressive hemodynamics at 24 and up to 72 hours with an index north of 3. On average, you see a quick reduction in vasoactive scores and only a 7% severe PGD rate, which given a cohort of 50% DCD in their population, I think is very impressive. I'll note that they're not quite at 10 degrees. You look at the average temperature that they're achieving, it's just over 8 degrees. So a range that's perhaps more similar to what we're achieving in the Sherpa system. So that's all I had. I think there's a lot of exciting data that we're learning more and more. I think hypothermia has certainly modified hypothermia has given us an additional ability to extend that ischemic time safely. I don't think we know yet what the safe upper limits are, but it clearly seems to exceed the 6 hours that we've limited ourselves to in the past. So look forward to further discussion.
Yeah, that's great, David. I think, you know, as we've all experienced, when we used the old, just sort of put it in a bag, put it in the igloo cooler and whatnot, it wasn't uncommon. It almost felt like it was frozen. And that was always sort of very troublesome and not good. On the other hand, I think all of us are sort of old enough. In the past, we tried doing heart surgery, right? Just regular heart surgery using continuous warm retrograde, right? Cardioplegia and whatnot. And although it can be done, it turns out it wasn't really reproducibly as good and as safe. And I think that's why a lot of people are sort of leaning towards, if possible, sort of the continuous cold perfusion, basically just like cardioplegia we do in the OR, most likely or potentially, has the opportunity to give us more reproducible results. What do you think?
Yeah, I think, the benefits of perfusion are pretty obvious. The downside of perfusion is that you do get a little bit more edema. I think the ex vivo and other systems have taken advantage of that low pressure perfusion system. I will say I've been impressed by the results that we've achieved with just simple static perfusion. The Paragonic system was designed initially as a perfusion system, and I do believe that they're going to come out with a perfusion system that we can test. I like it because it's simple. The ex vivo, I don't have any experience with. They certainly seem to be able to achieve good results, but it does appear a little bit more complex than the simple static type systems. I think the Achilles heel of all the cold perfusion systems is they don't give us the ability to evaluate an organ. And so you can use it with the NRP method, but you can't use it with a DCD method where you're not reanimating the heart to get some kind of functional analysis. And so I think that we still don't have that perfect device to do both of those things.
Mike?
Dave, it's a really great summary, and I too, we have moved we moved to using Sherpa Pack quite a bit, or the moderate whatever we want to call that, moderate hypothermia static storage, and have been very happy with it. I'm curious that maybe for the audience, but maybe what were the things that I imagine it was a combination of donor factors and recipient factors that made you guys comfortable with going all the way to Alaska from Boston? And we've thought about that here, and we're very aggressive about the organs we take, but did you have a really sick or really not sick donor or recipient? Yeah. And I assume it was a pretty young, perfect donor, right?
Yeah, I think it's a very fair question. And I think, we could, had that not gone well, we could easily be criticized. And if we did it again and it didn't go well, we could be criticized. And I think we could be criticized for even doing it once. We have
personally, I commend you for doing it. I think it's novel and it's logical, but I'm sure it was uncomfortable.
It was a combination of things. I think, I've looked quite a bit at the Guardian registry, and there really is no signal that we've gotten to a period where it's unsafe. So it certainly appears, if you just extend those curves outward, there's not a lot of patients in there, and so the noise gets a little bit louder. But it certainly appears that those are similar risks to what we used to take with 3 or 4 hours of ice, going up to 7 or 8 hours. And so there's registry data. Ali Rabi and others in our lab have really done a lot of work with all sorts of perfusion and cold storage. And we've got animal data that suggests that we can do this safe cold static storage for really several hours longer than we've been used to. This was a young donor. We thought at worst we might get a little PGD that we could resuscitate with ECMO. And as you know, we commonly do that in our DCD patients. As long as you apply ECMO judiciously and early on and don't allow the end organ dysfunction from missing your window, those patients resuscitate very well. So it was a combination of factors. Thankfully, we didn't need any of those things, but it hasn't, we took one the other day from way up in Canada. We did use a perfusion system. It would have been a similar ischemic time. So we still grapple with those decisions of which are safer.
So David, I applaud you because you've actually done something a lot of us haven't done, and that you've studied this in a systematic way, and similar to how Dr. Bowdish has studied their resources and the tools. What I struggle with, and you'll see in my talk as well, is a lot of it is the unknown. And so there's an incremental risk, and we know that stacking risk can be bad, taking a very sick patient in an organ. And but how do you guide your colleagues and friends who call you and say, what's okay, what do you know, and what's the unknown? Because the challenge is we're now sending all hearts from one country to another. I mean, certainly Dr. Bowdish's program could have used that heart in Alaska and it would have been closer, and you could have taken a heart that he was going to use in Oregon.
Yeah.
What do you tell your colleagues who call and say, should I be doing this?
Yeah. So I think that slide that that Michael showed, looking at, you know, the use of DCD, and there's a lot of centers that are using just a few DCD organs. There is a learning curve to certainly doing DCD transplants that most of us have suffered through. And I think that one of the advantages of the NOP, for example, is you don't suffer through the procurement part of that learning curve. You have professionals doing that part. I do think there's a learning curve on the recipient side, and the way that the conduct of that operation is different, and the way you resuscitate those donor hearts is different. I think, you know, Scott, as you know, we talk, we text, we give phone calls to each other, we do these webinars, and it's important that we learn from each other and from experiences. But, you know, the more experience you get, the more ability you have to accept some of these risks, and they're not easy. But as long as you have the tools and the breadth on your team to be able to resuscitate these patients, I think we can do it safely. I can't tell what's going on with my computer. It's making sort of, is that everybody's?
So
it's mine.
I want to make another comment. And so Aaron Schumer, who works with Mark Slaughter and I, we met on a procurement the other night to do something. And I was talking to our friend Nader Moazami, and he said, you're better than me because you'll still go out on procurements and you'll do this. And I will say to you that the era of when we were in training and we were young and had hair, the era of that, the attending stays back and the young people go procure, I feel is over, because we have to know what the conduct is there. We have to understand it. It is a completely different situation. It's a completely different circumstance. And for example, knowing what the functional warm ischemic time and the impact on that with the different techniques is very, very important for DCD. Knowing how the different perfusion systems will impact your operation. For you, Dave, as a clinical leader at the heart transplant program at the MGH, I think it's important to have some real on the ground experience. And I doubt that many people are actually doing it.
Yeah, I agree with you, Scott. Michael, we're going to wait 1 second because I want to make sure we give Dr. Silvestry enough time. And then we have a few minutes for audience questions, because we have 140 people eagerly waiting to ask a couple of questions. So we're going to forego the last polling question. This is more just to sort of get a feel for the audience. And Scott, why don't you go ahead and jump into the warm approach, the direct procurement.
All right, so I think you can see me, and then hopefully this will play and you can see this. So while organ preservation is the critical link that we're discussing, we really don't know what the optimum temperature is. And if we go for something as common as drinking a smooth beverage, we don't really even know what the ideal temperature for this is. As David has alluded to, there's a lot of significant research. This is in liver, and showing here the oxygen consumption versus temperature with and without a perfusion versus a solution. HTK, and in the top a novel solution, and you can see that oxygen consumption with time drops better with the solutions. However, when we look at perfusion, in this case a gas perfusate oxygenated perfusion in an animal model, we can see versus cold storage that the lactate levels are significantly lower in this element. Because one of the questions that I've asked, and we've had these conversations with intentional storage, such as Sherpa Pack, is why is it better? Is it just the temperature? Or is there something more? Is there an immunologic response? Are there issues with the temperature threshold to further ischemia reperfusion injury? And the fact is, we really don't know. if we dissect it out, we look at cold and the different types of perfusion and preservation. You have hypothermic machine perfusion, you have mid-thermic, you have subnormal thermic, then you have normal thermic machine perfusion, such as the transmedics. And all of this is a complex and expensive procedure. These are important because we don't know, and as we were on a discussion with this earlier, for example, with NRP, we don't know if normal thermia is the right answer or whether mild hypothermia to resuscitate the organ after it had ischemia, ischemic event with cardiac arrest is the way to go. And it really hasn't been studied, nor do we know what the optimum times to resuscitate. Most of the research, if you do a PubMed search on it, is in the vein of the things that David has brought up before, and that's whether it's the United States from Westchester Medical, or whether it's from Australia, New Zealand, with the ex vivo, or Transmedics or Sherpa. We're seeing anecdotal small series with cases as the baseline of what is right and what can be done. In this, we have 8 cases, several of which required ECMO, and you get the preservation time for patients with the DPP and looking at transmedics and the different distances. And it seems like we've entered into a literature game of who can go the furthest for the longest and see how it turns out. If we look at the outcomes in their secondary endpoints, there is no real statistical difference. There's differences in perfusion, but there are differences such as inotrope score, which favor OCS, but not statistically different. But the length of ICU stay in those patients is longer, but not statistically significant. So clinically different, but not statistically significant. And as David mentioned, I like to quote this because this is the French solution where a patient flew, a heart flew basically 13 hours to Paris, coach. And the heart came back and it did well and the patient was happy. But have we established markets where organs need to go 16 hours in order to get a single transplant in Paris? It's very interesting. And if you read this article, you'll see that the donor was age 48. So we will go 13 hours for a 48-year-old donor. As mentioned before, there are different options for cold. There's old cold, better cold, not cold, and the ex vivo cold. And when we look at the transmedics data, if you look at the FDA application and see all of the data put into one place, you can see the PROCEED-2 study, the test of feasibility, the PROCEED-2 OCS, again, approximately 130 patients in there with an average age in the 50s, and looking at what their outcomes were, proving that it can be done. And then the expand and expand cap, looking at the results of these, again, looking at the transplants. These are clearly higher risk groups. These are higher risk donors. These are long ischemic times in marginal donors. And you can see what the pump flow and the match refusals. These are real studies which show that we're pushing the envelope for this with reasonable results. And that if you look at the results in those 4 trials, again, separated by almost 15 years, you can see that post-transplant MCS is not insignificant, 27% for PGD. ECMO was 12% in the EXPAND trial, and that survival was equivalent. So we also learned that even though you may have primary graft function as opposed to dysfunction, that is a slow period for the graft to sort of wake up after a long travel with perfusion and several brief periods of rest, the general tendency is that survival was equivalent, as David had pointed out. And if we look at the EXPAND trial in detail as it was published in JACC, you can see the donor risks were prolonged time, age, LVH, downtime, and imperfect parts with either luminal irregularities, alcoholism, or multiple criteria. And looking at the recipient, these are a very sick population. When one looks at these together, you can see compared to a concurrent SRTR group that they're significantly sicker and that these patients have significantly more resources, statistically so. Yet when you look at the data, the success rate, success in the primary endpoint was heart transplant survival and freedom from PGD with a performance goal of 65 was really quite good at 88%. And with increased experience, the success rate in the EXPAND plus CAP was 92%. It's important when you dig into the supplemental data for OCS that many of the successes were in the higher volume centers, as was in the DCD, which are data that Michael Bowdish alluded to. that higher volume centers with more routine and more experience, perhaps both in the operation and also in the salvage and early salvage, had excellent success rates, freedom from PGD and transplant survival. And then if you look again, looking at the 30-day survival, severe PGD and 1-year survival for the different groups with the different risk factors overall, 1-year survival is excellent with the transmatics. Again, these are not DCD, these are marginal expanded criteria. 30-day survival was excellent. And the PGD rate overall severe was 6.7%, with some potential increase in the downtime patients and the LVH patients, age not really being a factor. And these are important because, as you say, when you evaluate these offers and you're choosing between multiple technologies with different pros and cons, knowing which heart should go on which support, I think is an important consideration. And David has alluded to some sophisticated decision-making in his process at the MGH. When you look at utilization, because of the resource use, you can see that utilization is 87% in the marginal donor expand trial, which is fairly good with a 13% turn down. And the reason for turn down predominantly related to the metabolic factors with lactate climbing in the turn down hearts and the trend generally increasing or not extracting in the transplanted hearts stabilizing significantly. And so from these data, we take away that this is very feasible and this can be done in a significant way with smart decisions, with a baseline and backbone of information that allows you to make decisions with confidence and develop risk mitigation strategies. So with the OCS, it's a promising technology with excellent utility. The cost is higher, but it has a role in both marginal donors and long distance utilization. Compared as ex vivo and Sherpa pack, as David alluded to, there is no direct comparison between these in marginal donors yet, and no direct comparison in the DCD arena between NRP and DPP. And the role in general for OCS and DCD is clearly established with good, excellent survival, and data comparing the NRP are pending with some single center series. Looking at perfusion with oxygenation, as David alluded to, ex vivo with David McGriffin and his group in Australia and New Zealand in the HOPE trial. Again, we've talked about this, that the inotropes tended to come down. This is a schematic which David has gone over with a proprietary solution called Steen solution and perfusion through the heart. Again, the mechanism, is it the solution, is it the cold, or is it the addition of both? I think that remains to be determined. And in this comparator trial, they use the ISHLT database, looking at the left on early graft failure versus 30-day all-cause mortality. And you can see that the ischemic time in hours with the ISHLT registry data, there's a linear relationship. And David, this is not Sherpa pack, this is standard ICE, ischemic time going up and having an increase in the early graft failure and the 30-day all-cause mortality. When then you graph this relationship for time versus mortality for the ISHLT database versus the HOPE cases, with as long as 8 hours and 47 minutes with no mortality in the group at all. So it's hard to compare apples to apples, looking at the donor population being slightly different. But as a result of this study, the group in Australia went to using this technology for all of their procurements and using it for all of their donors at that time, even though it hadn't been approved yet. And the last part is we eagerly await the PRESERVE trial, looking at the ex vivo in the United States, but also because now the DCD data is going to be included, and there's been several DCD hearts in this trial already from some high volume centers, multi-centers that are in the trial. And we look towards this to giving us a very good look at what the data looks like with an alternative perfusion. And so I'll end there and go back to the group with some data. But again, as David has pointed out, a lot of the data that we really want doesn't exist yet. It hasn't been compiled, and we're left drawing inferences and extrapolating what we know as opposed to having certainty in direct comparison in same populations. Thank you.
That's a great presentation, Scott. And as you have pointed out, we seem to be achieving sort of equivalent results, whether with direct procurement and continuous warm perfusion. And the question to say, with increasing experience and data, is there one that might be better in each scenario? And we really haven't had an opportunity to even touch on the idea that you need to change the recipient operation, right? Depending upon the donor, which system you use, and that aspect. But I want to give Dr. Schumer just a couple minutes here to see if there's some common themes and questions from the audience that she can pose to the panel. Erin?
So I think the main question is, is there a way that you decide recipients who to use DCD for, and do you change whether it's NRP or direct procurement and perfusion? And are they different statuses that you're considering DCD? So if you guys could address those issues.
So actually, why don't we go ahead and just start with you, Michael, and we'll just go right down the line. And I think sort of the idea is with all this technology, and it's really sort of touched on though, the issue is, who are you using DCD for? Is it only status 4? You know, is it status 6? Somebody at home? Do you use is it a high risk recipient where you're going to use a high risk donor, which historically, comes in with higher risk? So just sort of briefly, what's your sort of approach to this?
Yeah, it's a complicated question. It's also sort of a moving target. So in general, will say we started off quite conservative, sort of a lower age limit on the donor than we would have for a DBD donor. However, and then we initially were not doing re-ops and far distances and whatnot. We've pretty much eliminated that. We'll go anywhere for DCD at this point. We'll go up to into the 40s for a DCD donor. And I'd say the curves have more aligned. They're far more aligned now than they were a year ago as we become more comfortable with it. So it's really just been a comfort level. And then the one thing I will mention to Scott's point is that although we have a lot of fellows who do most of the DBD donors, the DCD donors, myself or one of my colleagues, or there's 2 others of us as well, we have done all the DCD donors ourselves, other than the OCS donors that we have. About half of them we have used the Transmedic procurement service. So I agree with Scott that I think there's a level of complexity there that you do have to be attentive to, at least, especially in these early stages in the US of using this technology.
So David, let me rephrase it a different way to be a bit more specific though. So for those programs, on that one graph that either aren't or getting started or low volume, I was always surprised because my impression was to initially, particularly with OCS, the idea was we're going to resuscitate hearts, and use sort of more marginal hearts. But at least initially in all the data, I was surprised that the average age of the donor was essentially the same as, a DBD, meaning 30 years of age. So what do you sort of look at when you're considering, you get a call for a DCD and they tell you they're 50, or they're 48, what effect does that have? Because historically, as I say so far, the majority of them have been though, around 30-ish to, mid to late 30s.
Most of the donors, as you probably know, are somehow related to opioids or drug use. And so they tend to be younger. The only data we have really, randomized data against was limited to donors less than 50. And we don't, nor should we be getting caths on these patients because they're not dead. And so we do have CAT scans very commonly, and you can get, you can look for coronary calcifications and those kinds of things. I think one of the advantages of reanimating the heart is you can assess it and see how it behaves in a heart with a lot of coronary disease you wouldn't expect would reanimate well. But the other advantage of the OCS is you can go, as Michael said, as far as you want really. And that's been the big advantage. That advantage may go away if ex vivo, if cold perfusion gives us the ability to travel safely across the country, then it may not matter. But we consider DCD donors for pretty much all our recipients. I will say that once in a while, you have to expect that some higher percentage of them might require ECMO. It's probably not 20% as it was in the trial, but it's more than 5%. So it's somewhere between 5 and 20% are going to require ECMO. And so a patient that might not tolerate an ECMO run, that has a higher bleeding risk, multi-redos or something like that, you might, think twice about a DCD donor. But we pretty much consider DCD donors on just about everybody. And it's about half of our organs are DCD in the last 3 years.
So before we get to what was I say? You raised a really interesting point that some, I'd say, people may not be, but technically these people, aren't dead yet. So the amount of information that you can get to assess that donor sometimes is less than what you would have in a brain dead donor. You can't cast someone who's not dead. You can't ask them to. So what effect? So let's just say they're 40 years old, were smoking, and had some diabetes. What are your concerns, or how does that alter when you can't get CAS or get additional information?
So a type 1 diabetic, we probably would not use at 40 years of age with smoking, but obese, type 2 diabetic with smoking, if their CAT scan, they almost always have CAT scans. If their CAT scan is pristine, there's no coronary calcification, then we'll go and we'll look and we'll put it on the machine. And the way we determined that the heart utilized lactate as an energy source was old data. That's how they used to diagnose coronary disease in the era before coronary angiography. So a heart that's got clinically significant coronary disease, you would not expect would behave well on a ex vivo perfusion system.
Yeah, very helpful. So Scott, what's your opinion?
I'm going to take the less scientific and more logistical approach. So number one, I believe that DCD organs, DCD hearts will probably ultimately be better because the hearts will not have gone through brain death. And I think that is going to be, is going to come out. And there's a lot of data suggesting that their clinical courses are more benign. Number two, you have to be aware in your program of what your salvage tools are and your threshold for salvage. You can't do a whole bunch of DCDs and then have the intensivist and team walking around saying, why are the heart transplants so sick all of a sudden? You have to understand that there is some level of primary graft function, slow to wake up, as David says, and you have to be clear what you're willing to do and what the patients that you are going to do this to are willing to accept. Older patients may not be the best because they may not tolerate an ECMO run if they're 73 years old. Coordination is very important. We have very well-aligned systems where we have timing of the operation. The heart doesn't get back without the heart being nearly ready to come out in a 5th time redo TAH. And so our precision in our system is good, and that is thrown to the wind with a lot of the DCD systems and the timing, because you just don't know when they're going to pass. And if they're local, you may or may not have a heart sitting in the corner. I think it's very important to risk mitigate and risk share with the team. The team should decide what is an acceptable risk and what is an acceptable, and that's all the stakeholders, the cardiologists, the surgeons. It's not simply a surgical decision, and you have to look at your goals for an individual patient. Is the goal to get the patient transplanted, or is this someone who would have a 20-year survival, and are we potentially compromising it in that way? And I think it is very, very important. And it's important to measure it and study it in your program and say, how are we doing in terms of success with the decisions that we're making so we can make better decisions? And as a community, we need to track this so we can advise each other as to what works and what doesn't work. It's very, very important, because doing these things without data or blind data is significantly, is not the best way to practice medicine. And I'll stop there.
So we just have a couple minutes left, and I think everyone has alluded to the fact that sometimes these hearts need a little extra time to reanimate and rest. And so clearly high inotropes, things like that would not be good. So one question for you, Scott, so is how do you approach ECMO? Meaning, is it central ECMO? Do you use peripheral ECMO? And similarly, is sort of what is your trigger? So you're on a little bit of inotrope, the index is about 2, the echo is not bad. So in the DCD heart, what is your trigger for it needs a day or 2 of rest? I'm going to put them on ECMO.
So I think that most of us would say that the threshold for DCD hearts, depending on how they're brought back or how they looked when they went to sleep, they were assessed, is going to be much lower. I would say 2 vasoactive inotrope score greater than 20, or 2 moderate inotropes with the addition of a pressor, you should consider mechanical support, and you should look at the lesion. If it's global, you consider ECMO. I happen to like central ECMO. Peripheral is fine, but central ECMO, when you can close the chest, would be helpful if you can do it in such a way that you can do that. Or the alternative, depending on if it's a single ventricle lesion, right or left, you can consider balloon pump and or other devices in that way. But I think the threshold is low. And then also, when you bring them to the unit, I know that Michael and David would say this, that many times when you bring a patient to the unit after a transplant on ECMO, people hunker down for 5 to 7 days. And that's not the case with some of these primary graft flow function hearts. Really, you want to be thinking about getting them off at 48 to 72 hours. You want to assess them and push them. And it's not the same as these other hearts with the DBDs, where for whatever reason you went 12 hours to, Russia and brought a heart back, and now it's not moving, and so you're going to stay on ECMO for 7 days, and it's going to be slow. These, you maintain inotropes and you push, and I'd love to hear my colleagues' opinion on that, but that was my observation.
Yeah, so Michael and David, why don't you each closing comment, suggestion, give Scott some advice, and then we'll wrap it up.
I agree completely with Scott regarding ECMO. I think it's a little bit lower of a bar, and early is better than late with these patients, and also getting them off earlier than later. So, and I would I think that we as a community need to. Scott alluded to this, but I think it's really important that we all come together to try to figure out how to work together to get organs to each other, and in a way that doesn't make us all get even more older and grayer and and less sleep and more sleep deprived. And because I think DCD really can potentially change the landscape of heart transplantation in the US, but it requires a level of coordination that's probably different than what we've experienced the last 25 years.
Yeah, I'll just end by saying, I think we should give ourselves a lot of credit. I think we're applying science to an area that has been largely abandoned for 50 years. I think it was Shaw published a paper around 2009, just looking at all the different preservation solutions used in the UNOS database. And I think, if memory serves, it was 144 different things that were used to preserve hearts. There was no data on any of that. Nobody was looking at this. Many of us were sending, our lab residents out to get hearts with very little supervision. So I think the process of organ procurement has come a long way, and I think we're spending a lot more time looking at it, which is the way it ought to be. And Scott, it's hard to disagree with you. You're a master clinician. We don't have a trigger is the answer to your question. Maybe we ought to have one. I will say, I've been, most of the time these hearts, even when they're struggling a little bit, will really rebound in that first 24 hours and they look great by the next morning, but it doesn't always happen. So we sometimes we're too aggressive in ECMO, sometimes we're not aggressive enough. I think the point is that if you're going to bring someone up to the ICU that's struggling a little bit, you got to be all over them. And the second that the parameters start looking bad or they start getting renal dysfunction, they got to go on ECMO quickly. We do tend to try to use more peripheral ECMO just to get the chest closed. And it's 3 to 4 days is what they almost always need. It's rarely more than that. And as long as you're judicious about the application, which ideally is in the operating room, but if it's within the first few hours, that's usually fine also. But I still find it a little hard to predict which ones are going to get better and which ones are not. It's an evolving science.
Well, I want to thank all the panelists. This has been a tremendous educational opportunity and a great discussion. And to say, I think that specifically in the last few years, we really have helped move the field forward. And I think it's evident by more patients are being transplanted. There's a decreased wait time, decreased mortality on the wait list. And quite frankly, we're doing older and sicker people. And I say, I think it's a real tribute, to those sort of at the forefront, which includes the three of you. So I want to take the opportunity also to thank CTSNet and John. We couldn't do this without CTSNet. They do a tremendous job, and to all the participants. And so, John, I'll give you the final word from CTSNet as our sponsor.
Thank you for attending this ASAIO Journal webinar held in collaboration with CTSNet. As a reminder, a recording of today's webinar will be available next Tuesday on ctsnet.org and CTSNet's YouTube channel. Save the date for ASAIO's 70th annual conference, happening May 29th through June 1st. Have a wonderful rest of your day.
Thank you once again to all the panelists and all the participants. I think this has been a great opportunity. Thank you very much and goodbye.
Thank you.
Thank you, Mark.
Thank you.